Hello and welcome to Chronic Pain Tips for Patients, a podcast created to help people living with chronic pain better understand their condition, the treatment options, and the questions they should ask before making decisions about their care. My name is Yuri Martins. I'm a board certified chronic pain management doctor in the St. Louis and Southern Illinois area, and today we are going to talk about trigger point injections, also called TPIs. Trigger point injections are commonly used in pain management clinics to treat a type of muscle pain called myofascial pain. The word myofascial refers to pain involving muscles and the connective tissue around them. This kind of pain can happen by itself, but it can also be part of other pain conditions. For example, when you have pain or inflammation coming from a joint, you can also develop pain in the muscles around that joint or limb because your body starts to use these muscles in a more intense way to protect that joint or limb that is hurting. So the goal of today's episode is to explain what trigger points are, what trigger point injections are meant to do, what are the risks, what are the benefits, and why the specific medication injected may not be as important as many patients imagine. As always, this podcast is for education only. It does not replace medical advice from your own clinician. Your situation may be different, so decisions about treatment should be made with a qualified healthcare professional who has examined you and understands your medical history. So, what is a trigger point? Many patients describe muscle pain as a knot. They may say, I have a knot in my neck, or there is one spot in my shoulder blade that always hurts, or when someone presses on the area, the pain shoots somewhere else. This is close to what doctors mean when they talk about trigger point. A trigger point is a localized painful area within a muscle. It's often associated with a tight muscle, sometimes called a taut band. When the area when the area is pressed, it may hurt. It can be both locally, but it may also send pain to another area in a recognizable pattern. For example, a trigger point in the neck or shoulder region may cause pain that travels toward the head, shoulder, or upper back. A trigger point in the low back or buttock region may contribute to pain that feels like it spreads into nearby areas. Not every tender point is a trigger point. A tender point is simply an area that hurts when pressed. A trigger point is more specific. It's usually associated with a taut band and may reproduce a familiar pain pattern when pressure is applied. Some trigger points are called active trigger points. These hurt even without pressure and can contribute to continuous ongoing pain. Others are called latent trigger points. These may not hurt all the time, but they become painful when pressed. The important idea here is trigger points are one possible source of pain, especially when the pain feels deep, aching, localized, and related to muscle tightness or spasms. So, what is a trigger point injection? A trigger point injection is a procedure in which a clinician places a small needle into the painful trigger point. A small amount of a solution may be injected, often a local anesthetic, such as lidocaine or bupivacaine. Sometimes saline is used. Sometimes a corticosteroid is used, although, as we'll discuss later, the steroids do not always add meaningful benefit and may increase injection discomfort. The goal at the end is to reduce pain, decrease muscle tension, improve movement, and help break the cycle of pain and guarding. Many patients with myofascial pain develop a pattern where pain causes muscle tightening. The muscle tightening causes more pain, and the pain then makes it harder to move, stretch, exercise, or participate in physical therapy. Trigger point injections may help interrupt that cycle, especially when pain is preventing someone from participating in rehabilitation. For some patients, the relief can be relatively quick. Some people feel better the same day or within 24 hours. Others may feel sore for a day or two before improvement becomes noticeable. And some patients may not respond much at all. This is one of the most important things to understand about pain care. A procedure can be reasonable and still not work for everyone. How do trigger point injections work? Many patients assume that the medication injected is the main reason trigger point injections work. That may not be completely true. Research suggests that mechanical effect of the needle itself may be the major part of the treatment. In other words, placing the needle into the trigger point and disrupting the tight muscle band may be more important than the exact medication injected. One important clue is something called a local twitch response. This is a brief, involuntary contraction of the muscle when the needle reaches the trigger point. In many studies and guidelines, producing a local twitch response is associated with better outcomes. That suggests that accurate needle placement into the trigger point matters. This is also why clinicians may spend time carefully examining the painful area before doing the injection. They are not simply injecting where it hurts, they are trying to identify the actual trigger point, the taut band, and the area most likely to reproduce your familiar pain. So, if you know, for example, exactly where your trigger point is, it's very helpful to tell your clinician or your doctor where exactly it is so we can inject exactly where it hurts. Does the medication used in the injection matter? This is a very practical question. Patients often ask, what are you injecting? Is there a steroid in it? Is one medication better than another? The answer is complicated. Across multiple randomized trials and guidelines, the overall finding is that the type of injectate often does not make a major clinically meaningful difference in pain outcomes for trigger point injections. In many studies, local anesthetic injections and saline injections produce similar results as long as the needle reaches the correct muscle area. That does not mean the injected fluid is irrelevant. Local anesthetics sometimes can reduce immediate discomfort and may make the procedure more tolerable for some patients. On the opposite side, injecting local anesthetics sometimes is painful during the injection, and some patients prefer saline over local anesthetic. The bottom line is that studies comparing local anesthetics such as lidocaine or bupivacaine with saline have often found similar pain relief. And the evidence actually suggests that the needle mechanical effect on the trigger point may be the primary therapeutic mechanism, while the specific fluid injected may play a secondary role. Also, some studies comparing botulinum toxin, also known as Botox, with other injections, and these studies have not shown consistent superiority. Therefore, Botox may have a role in selected medically refractory cases, but is not usually considered the first line injected for routine trigger point injections. And what I also tell patients, every time we are doing a treatment that does not have much data supporting it, it's much more difficult to get approval from your insurance to proceed. It doesn't mean that it's not the correct procedure for you. It just means it's going to be a tough battle. What about steroids? Many patients associate injections with corticosteroids. However, for trigger point injections, adding steroids to local anesthetic has not consistently shown added benefit. In fact, some guidelines note that steroids may increase injection pain without clearly improving outcomes. Steroids also carry their own potential local side effects, including skin or fat tissue thinning. So, in practical terms, a reasonable first line approach often involves a small amount of dilute local anesthetic or saline combined with careful needle placement into the trigger point. The key message is this: for trigger point injections, the needle finding the right spot may matter more than using a stronger medication. What about dry needling? You may also have heard about it. Dry needling means that a needle is placed into the trigger point without injecting medication at all. Wet needling means that some fluid is injected, so as we commonly do trigger point injections, and dry needling is basically just putting the needle inside the trigger point. The evidence suggests that wet needling may provide better short-term pain relief than dry needling in some patients, especially when local anesthetic is used. However, long-term outcomes may be more similar. This is another area where expectations matter. Trigger point injections may help reduce pain in the short term and may make it easier to move, stretch, or participate in therapy, but they are often most useful when they are part of a broader treatment plan rather than the entire plan by themselves. So, what are the benefits of trigger point injections? The main possible benefit is pain relief. For some patients, reducing trigger point pain can make it easier to move the neck, shoulder, back, hip, or the area that is hurting. It can help decrease muscle guarding, it can improve range of motion, it can make physical therapy or home exercises more tolerable. In summary, it can make life better with less pain. Trigger point injections may also reduce the need for other pain medications in some patients, particularly when the pain is localized and clearly myofascial. They are usually performed in an outpatient setting and are generally considered low risk when performed by trained clinicians using appropriate technique. But low risk doesn't mean no risk. That distinction is important. So let's talk about the common risks. The most common issue after trigger point injections are temporary pain at the injection site and post-injection soreness. Some patients feel bruised or achy afterward. Mild numbness can occur when local anesthetic is used. Bruising can also happen, especially if a small blood vessel is irritated by the needle. Bleeding is usually minor, but it can be more important in patients taking blood thinners or antiplatelet medications, such as clopidogrel. Trigger point injections are often considered low risk from a bleeding standpoint, but your doctor still needs to know if you take aspirin, warfarin, apixaban, rivaroxaban, clopidogrel. In summary, if you're taking a blood thinner, please tell your chronic pain doctor before you get any procedure. Okay? And this is really important. Another possible reaction is vasovagal syncope, which is the medical term for fainting or nearly fainting during a procedure. This can happen when someone is anxious, sensitive to needles, or how do we call it, needle phobic, dehydrated, or prone to fainting. The heart rate and blood pressure may drop temporarily, reducing blood flow to the brain. Usually, lying the patient flat and monitoring them is enough, but the care team needs to know if you have a history of fainting during medical procedures, so we can prepare ourselves to treat you if vasovagal reactions occur. Infections and other possible risks with any injection. Most infections are prevented by cleaning the skin carefully and avoiding injections through infected skin. Rarely, superficial skin infection or deeper tissue abscess can occur and may require antibiotic or drainage. Allergic reactions are possible, especially to local anesthetics or other injected agents, although true allergy to local anesthetic is uncommon. Still, you should always tell your clinician about prior reactions to numbing medications, steroids, antiseptics, adhesive tape, or latex. And what are the less common but serious risks? Serious complications are rare, but patients deserve to know that they have been described. One of the best known serious complications is pneumothorax, sometimes called a collapsed lung. This can happen if a needle enters the space around the lung and allows air to collect between the lung and the chest wall. This risk is especially relevant when trigger point injections are performed in areas near the upper back, shoulder, neck, and chest wall, such as the trapezius, the supraspinatus muscle, the levator scapular muscles, the rhomboids, or other cervical thoracic muscles. Basically, if you're working close to your chest wall or in your chest wall. Symptoms of pneumothorax may include chest pain, shortness of breath, pain with breathing or cough, or feeling suddenly unwell after an injection. Treatment depends on the size and severity. Some cases can be just observed. Others may require oxygen or placement of a chest tube. Another rare but severe complication is spinal cord injury, which has been reported in case reports involving paraspinal muscle trigger point injections. This can occur if a needle is placed too deeply into the wrong direction near the spine. Symptoms could include knee weakness, numbness, severe pain, or neurologic changes. So you're telling me I can be paralyzed from trigger point injections? Unfortunately, there are cases in the literature, but the risk is very, very rare. And what I tell patients is we do millions of trigger point injections in the USA only every year. And there are cases in the literature about paralysis. So the risk is very low, and there's no way I can give you a percentage about it, but it's there. Other very rare complications described in the literature include vascular injury, visceral injury, pneumocephalus, necrotizing mediastinitis, that is an infection in your mediastinum, other severe infections, and deep abscess formation. These are uncommon, but they are part of the reason that even a simple procedure should be performed with respect for anatomy and patient safety. Local anesthetic systemic toxicity, often called LAST, is another rare but important risk. This happens when local anesthetic reaches a high enough level in the bloodstream to affect the brain or the heart. Symptoms can include ringing in the ears, metallic taste, dizziness, confusion, seizures, or heart rhythm problems. These are rare complications with the small volumes usually used in trigger point injections, but is still a recognized potential complication. Severe changes in potassium, including hypokalemic paralysis, have also been described rarely. Severe muscle toxicity from local anesthetics has been seen in experimental models, although clinically significant cases after trigger point injections are rare. Again, most patients do not experience these complications, but informed consent should include not only the common temporary effects, but also the rare serious ones. How can I reduce the risk for complication? Risk reduction starts with patient selection, good technique, and clear communication. Your clinician should know your medical history, medications, allergies, bleeding risk, prior reactions to procedures, and whether you have an active infection. For injections near the chest wall, upper back, or neck region, ultrasound guidance may help reduce the risk of pneumothorax by allowing the clinician to see important structures, including the pleura, which is the lining around the lung. Ultrasound can also help identify muscles, guide needle path, and avoid vulnerable structures. Imaging guidance may also be useful for paraspinal muscle injections, where avoiding deeper structures is especially important. This does not mean every trigger point injection must be done with ultrasound. Many are safely performed using careful landmark based technique, but in higher risk areas, in patients with difficult anatomy, or when landmarks are unclear, imaging guidance can be helpful. And who should not have trigger point injections at all? There are situations where trigger point injections may not be appropriate. The most obvious is patient refusal. No procedure should be performed. No procedure should be performed if the patient does not want it or does not understand why it's being done. Active infection over the injection site is another contraindication. Inserting a needle through infected skin can spread the infection deeper into the tissue. A known allergy to the planned anesthetic or injected medication may also prevent the procedure, unless an alternative can be used. Other contraindications may include fracture at the injection site, certain school defects for head and neck injections, and in some cases the use of specific anticoagulants or antiplatelet medications, depending on the location of the injection and the patient's risk. There are also relative contraindications. These are situations where the procedure may still be possible, but extra caution is needed. Examples include systemic infection, pregnancy, a history of vasovagal reactions, and obesity or other anatomic factors that make landmark difficult to identify. The decision should be individualized. Are trigger point injections the only treatment? No. Trigger point injections are just one tool. They are not the entire toolbox. Other options may include physical therapy, stretching, strengthening, posture work, ergonomic changes, heat, massage, acupuncture, dry needling, anti-inflammatory medications, muscle relaxants, topical medications, the sleep optimization, stress reduction, and treatment of the underlying pain generators. Often, trigger point injections work best when they create a window to reduce pain that allows the patient to move better and participate more fully in rehabilitation. In other words, the injection may open the door, but movement and functional restoration often help keep the door open. If the same trigger point keeps returning, your doctor may need to ask why. Is there an underlying spine problem, a joint problem, poor posture, repetitive strain, weakness, poor sleep, stress related muscle tension, an untreated nerve issue? So, because of this, that pain doctors are so important. The goal is not only to chase the painful spot, the goal is to understand why the painful spot is there. So, what should patient ask before trigger point injection? Before having a trigger point injection, it's reasonable to ask your clinician what muscles they think are involved, why they believe the pain is myofascial, what medication they plan to inject, whether steroid is necessary, what risks apply to your specific injection location, and whether ultrasound guidance would be useful. You should also ask what to expect afterward. Should you rest? Should you stretch? Should you go to physical therapy? When should you call the clinic? What symptoms would be concerning? Good procedures are not just about the needle, they are about the plan before and after the needle. So let's talk about it. What should you expect afterward? After a trigger point injection, some soreness is common. This usually improves within a day or two. Some patients feel immediate relief from the numbing medication, but that first improvement may wear off after a few hours. Longer lasting benefit, if it occurs, may develop over the next day or several days. Your clinician may recommend gentle stretching, heat or ice, activity modification, or physical therapy. The specific instructions depend on your condition and how the procedure was performed. You should contact your healthcare team urgently if you develop chest pain, shortness of breath, severe worsening pain, fever, spreading redness, any kind of drainage through the puncture wounds, new weakness, severe numbness, or other concerning symptoms. Most patients do not have serious problems, but knowing what to watch for is part of a safe care. So, what is the bottom line? Trigger point injections can be a useful treatment for selected patients with myofascial pain. They may help reduce localized muscle pain, improve movement, and make it easier to participate in physical therapy or other treatments. They are generally considered low risk procedures, but they are not risk free. Common side effects include temporary soreness, bruising, bleeding, numbness, and discomfort. Rare but serious complications, including pneumothorax infection, nerve injury, spinal cord injury, and local anesthetic toxicity, have been described. The evidence also suggests something many patients find surprising. The specific medication injected may not be the most important part of the procedure. In many cases, saline and local anesthetic have similar outcomes, and adding steroids does not clearly improve results. The mechanical effect of the needle, especially when it reaches the trigger point and produces a local twitch response, may be a major reason the treatment works. So the key questions are not only what are you injecting, they are also, is this really a trigger point? Is this the right target? Is this procedure appropriate for my pain pattern? What are the risks in this location? And how does this fit into my broader treatment plan? Trigger point injections can help, but they are best understood as part of a larger strategy to reduce pain, improve movement, and help you get back to the activities that matter. So, most of the time, they're using temporarily to give you pain relief so you can go back to physical therapy, stretching, and exercises to improve your pain. Thank you for listening to the Chronic Pain Tips for Patients. My goal is to help you understand your pain, ask better questions, and make more informed decisions about your care.